All right. Welcome, everyone, to our seventh Learning Collaborative of our Center of Excellence bi-monthly series. My name is Clement. I'm the academic detailer clinical pharmacist here with the Northern New Jersey Center of Excellence. Today, we'll be talking about the integration of MAT in the New Jersey criminal justice system. And as you may know, approximately like 75% of patients who are incarcerated have some type of substance use disorder. And among those who are discharged and that have OUD, a high percentage of them are very likely to die compared to the general population. We'll discuss the historical perspective of MAT as well as treatment of MAT in this setting. And of course, one of the most important topics include the idea of discharging patients into society and the emphasis on transitions of care. So just some ground rules. Please ensure you are muted during the presentation. Upon joining, you should already be muted automatically. You may use the chat function at any time to ask a question, and we will address them at the end of the presentation. Dr. Kaldany may also ask a question during the presentation, which you can feel free to unmute yourself or use the chat function. If you wish to ask your question verbally, please hold that question until the end and make sure to remute after unmuting yourself. We'll be releasing a survey through our listserv to ask for your feedback as well as topics you want to learn for our upcoming learning collaboratives, so please be on the lookout for those. Today we have Dr. Herbert Kaldany, who will be leading this talk on MAT in the criminal justice system. He is the New Jersey Department of Corrections Director of Psychiatry and Addiction Services and has served in this role for over 15 years. He oversees all aspects of mental health services and supervises much of the quality improvement initiatives at the Department of Corrections. He has directed all addictions programs and services there and was also elected to the Executive Administration Team of the Mental Health Network of Correctional Mental Health Directors. He received his Doctor of Osteopathic Medicine degree from what is now part of Rowan, the UMDNJ, in 1992, and also did his psychiatry residency thereafter. So without further ado, here's Dr. Herbert Kaldany.
Thank you very much for that introduction, Clement. And let me also say, in terms of full transparency, I'm not a board-certified addictions physician. I am self-taught, and many of the slides that you'll see today come from Dr. Erin Zerbo, who was one of my mentors, and she I look to as sort of the expert in addictions. And so she was kind enough to lend me some of her slides, which a few of them I've modified for our talk today. So let's jump into our discussion today. And you see from the topic, it's a culture shift in the treatment of addiction in correctional settings. And I picked the word culture specifically because it's a multifactorial shift. And if you look at the pictures on the screen on the very bottom left, you see the shift button on a keyboard. So if you were just talking about a shift button, that's only two options, either small case or uppercase. So it's not just a two-factor approach when you're talking about culture. The middle picture there, which says attention, paradigm shift, some folks are familiar with paradigm shifts where it is a linear progression. Generally, in terms of what science understands, happens in a linear fashion, and the paradigm shift occurs when a new theory sort of encompasses a way of explaining things that are unknown to science, but it is progressive, forward. And then at the bottom right, you see the picture of an automobile gear shifting mechanism. And I actually liken the culture shift more to an automobile gear shift in that in the culture shift in corrections, there's been some forward steps that we've taken and we've gone backwards at times. And so I just use that as the analogy for us to keep in mind when we're talking about the culture shift in correctional settings for addiction. It has really been all over the map, has not been always linear. So let's go to the next slide and we'll begin to outline what our objectives and missions are for today. So the picture at the top is a picture of the Voyager. passing through space. So we're going to go through all of these different objectives, and we will then take a look as we pass through them what we learn. So we really want to have you understand that the information I'll present to you is based on how in corrections, at least in the New Jersey Department of Corrections, we've had to shift our culture from a punitive approach to a treatment-based approach. And so in order to, if that's our main mission, I'm going to walk you through these objectives. One, we'll discuss the laws which grew the incarceration population based on drug use. And then the second objective will be briefly going over the new science of addiction. And so the picture there at the right says weird science, because when I have to introduce this to our correctional staff, for them, the science of addiction is weird to them. They don't understand it. They're still based on old ideas of addiction. And so I'll explain what the new science is. We'll go over, in terms of the next two objectives, what kind of shift we experience both at the Department of Corrections level, which is the state level, and then at the jail level. And then on the fifth objective, we'll talk about some of the culture shift at the community level. And then we'll finalize our last two objectives, as Clement said, making connections between many of these pieces as they relate to entry and release. And all of the pieces that I mentioned in the objectives above are interrelated. And again, thinking of the shifting of the gears analogy, a person often passes through many different settings, whether it be a jail, the Department of Corrections, back to the community, back to the jail. And sometimes if it's a parolee, they'll skip the jail part and they'll come back to the Department of Corrections. And then finally, I'll go over some outcomes and data so that you can have a sense of how things are going and what has been the impact at the Department of Corrections. So this is a slide that some people may have seen before. I've seen this presented in many different lectures, actually. And usually when this slide is presented, you can see that it's a presentation. At the very top, you have the solid line, which is a line that shows the total population per 100,000 of institutionalization. And they break it out into the longer dashed line, which is those that are in a psychiatric or mental hospital. And it dates back from the bottom left corner, 1928, and it goes through about the year 2000. And then the smaller dashed line on the lower part is the prison population. And in some lectures that I've been where this was presented, it was used as evidence that as you see the decline in the number of people hospitalized in a mental hospital, this was the so-called deinstitutionalization process that occurred in the United States, starting in the 50s and progressing through the 70s, that this slide was actually used to explain why in the prison population, the number of people who are suffering from mental illness began to rise. There was this theory that as people who were sent out of psychiatric hospitals, that they ended up in prisons. Unfortunately, that theory is not very accurate, in fact. If you look carefully at this slide, at around 1976, at the bottom, you see that the long dashed line for mental hospitalization rates continues to drop. And throughout this period where that long dashed line continued to drop, there was no increase in the number of people who were in prison. My point on this is to say that most people with psychiatric illness are not going to engage in criminal behavior. And therefore, the amount of people that were deinstitutionalized from mental hospitals did not end up in prison. Yet if you follow the dashed line of the prison population, you see begins to rise in the 80s. And it continues to rise, and the number of people in prison begins to account for the great majority of people who are institutionalized. You can see the solid line just continues to rapidly go up. That had nothing to do with the institutionalization of the mentally ill. There was something else going on. And so I present this for people to consider that that rise was exquisitely tied into drug laws. And so if we go to the next slide, we'll see that this recaps that the mentally ill people hospitalized dropped from the 50s to the 70s. That was designed to empty the hospitals. And while there was no increase in the prison census, it started in the 80s and it rose because for the first time, addiction became something that you could be arrested for. And in the 80s, it was the time of the mandatory drug sentencing laws, such as the Rockefeller drug laws in New York, and the 3 strikes and you're out. Some people would say it's the 3 strikes and you're in if you come from the perspective of the prison. In other words, if you were arrested 3 times in California for possession, not sale, but possession of drugs, you were incarcerated. So many other states, based on what was going on in both New York and California, began to pass their own mandatory drug sentencing laws. And that caused the rise in the incarceration rate. And the other part of that graph shows exquisitely then that that's what happened to increase the rate of incarceration. It also laid down the foundation for the culture in the prison setting that people with addictions were to be punished, because the greatest driving factor within a correctional setting is that we're here to basically dole out the punishment portion of the sentencing when the judge determines that a person needs to go to a jail or prison. So this is sort of just to help folks understand that this is what was going on. This laid down the groundwork for the majority of the culture in the prison setting. And you see there on the second bullet, if we are still hanging on to the thought that the deinstitutionalization of the psychiatric population was the reason for the rise in the census in the prisons, it gets even more interesting if you look at the commitment laws. This is where the psychiatric commitment laws began to get passed nationally that would limit the power of the state to commit to a hospital only in cases where that person posed an imminent danger to themselves, others, or properties. This went along with the deinstitutionalization movement of the 50s, 60s, and 70s to protect people who were mentally ill from being committed by the state. And in this case, it would be committed to a hospital. However, that protection was not afforded to people who had an addictions problem. And the graph does illustrate that the state was permitted to commit to prisons, and that is why we see the very large rise in the incarcerated population from the 80s to the present day, which goes back to what Clement said earlier, that we see about 75% of people with some sort of a substance use disorder. I won't go so far as to say a full-blown addiction. That's a more significant version of a substance use disorder, but at least 70 to 75% is what we see in New Jersey. So how did the addiction laws tie into, and I will use the acronym of MOUD, which is the medications for opioid use disorders. I will do my best to move away from the term MAT. Some of my colleagues have indicated to me that MAT sort of embodies a bit of stigma, and so I am going to use MOUD instead of MAT. You may hear me have a forked tongue at times, and I will slip up and still say MAT. You'll have to forgive me for that. But the mandatory drug sentencing came about because it was in part the main tool that society had for addressing the safety through punishment rather than treatment. There were not many forms of treatment. Even methadone as a treatment, if you're looking at just the medications, although it was around from the 60s and even 50s, it was very stigmatizing. And in fact, buprenorphine was around in the 80s. I think it was in 1984 that the FDA approved buprenorphine. Just as an aside, I remember in the 90s attending a conference on HIV, which was one of my other interests, and I went to that conference, and there was a seminar on buprenorphine as this partial agonist. I sat in that conference, and that was what triggered my interest in learning about addictions. And that was in the early 90s. I was already working in the prison, and the presenter did not have a lot of information to explain how the medication worked or its outcomes. So we've come a long way from then to now. So in 2020, SAMHSA has a report that it still publishes that there's an estimate that only 1% of all prisons and jails offer medications for opioid use disorder. This is despite it being the gold standard. Now, there is unpublished research done by the Correctional Mental Health Network, and that's the network that I belong to. This was done in 2017, and I know that this is unpublished because I was one of the researchers, and we polled all of the departments of corrections across the state, all 50, and we included 6 large city departments of corrections. And actually the number there rises to about 40% that offer some form of medications for opioid use disorder. We were able to qualify an organization if it offered only 1 out of the 3 main ones for opioid use disorders. If we expand it to all the medications available for all substance use, that would expand it to 8 FDA-approved medications because that includes alcohol. But we opted to only focus on opioid use disorders. So if you look at the state level, it appears to be doing a little bit better, but there's more that could be done. I'm going to state that medications for opioid use disorder became a gold standard around 2015 or so. That's just based on my own experience. Yet during that time, it remained very unpopular in the criminal justice system. And here are some reasons why I believe it was unpopular. One, the view is that addiction is a choice. It's a moral failing rather than a brain disease disorder. And I do need to credit former Governor Christie, who was the first public official that I'm aware of that actually advocated for addiction being a brain disorder. The other reason is that addiction is viewed as illegal, and that was going back to our mandated drug sentencing laws that we talked about earlier that were around since the 80s. So all of these things led to a culture of viewing addiction as an illegal act rather than a healthcare problem. And it also defines people with addiction as an addict rather than to look at the person on the whole as a person who has an addiction rather than to call the person an addict. It's like in mental health, we see sometimes folks refer to their patient as that schizophrenic rather than a person with schizophrenia. So we're trying to change the language because it does have an impact on what we do. And finally, the other factor that led to this view of MOUD being unpopular is because the treatment of most opioid use disorders mainly followed a community detoxification protocol, particularly at the jail level when the person is coming in right off the street. At best, the person was either detoxed using a detox protocol or they were allowed to detox without any detox protocol, and that led, unfortunately, to many suicides. And I was involved in reviewing many cases of that unfortunate experience for many people coming into a jail system. The jail system has made a remarkable improvement in New Jersey. So we're done with our first objective. I'm going to talk a little bit about the new science of addiction and what modern science reveals about addiction. For those of you who have been through these kinds of discussions, this should be a review for you. For those who have not, it's important to recap this because this is what we do in corrections. We need to repeatedly teach people about what the new science of addiction reveals, focusing on the fact that it is a brain disorder, it is a disease, and that when we treat the brain, the behavior shift. So we talked about a cultural shift in the settings that we're treating people. The other half of the shift involves that we change the behavior of the offenders, the people who are incarcerated, when we treat their brain as we would for any other brain disorder, whether it's a seizure disorder or stroke. If you treat it, then the behavior will shift. The same is true for addictions. And by the way, here's our interactive point in the webinar. The Just Say No campaign remains a huge failure. This was another proposition that was promulgated by the wife of one of our presidents. And if you're so inclined to respond, I'm going to ask you if you could type in who you think started the Just Say No campaign. And I'm going to give you a couple of choices. The choice would be that it was either Nancy Reagan, Michelle Obama, Betty Ford, or Barbara Bush. So if you think you'd like to participate and give one of those names, go ahead and type it in. We'll see if somebody could come up with the answer, and I'm going to go ahead and give you the answer in a moment. So we're able to see that we have a very bright audience. So far, everybody has responded the correct answer, and it is Nancy Reagan. So kudos to the people who know this. Nancy Reagan started this campaign, and she had a good heart. She was trying to help people with addictions, and she was following the culture, which was to view this as a moral failing and the ability to just say no. You'll learn in this webinar why it doesn't work. And it leads us to whether we believe addiction is a choice. And so that little cartoon there is to sort of point out to us, do we think it's as simple as walking through door A or door B? Yes, I'm going to just say no going through door A and I can remain drug-free, or B, no, I'm going to continue and I'll continue my addiction. And by the way, it is unfortunate that historically people with a heroin addiction usually go through about 8 to 9 rehabilitation admissions before they can have 1 year of sustained sobriety. And therefore, that evidence or that data is evidence for why just saying no remains a huge failure. So let's now go into a little bit about the new science of addiction, and here we have a view, a cartoonized view of our brain, looking at the brain from the side, and you'll see there in the on the far right corner where actually there's the bright pink area that says the vision. By the way, that's the back of the brain. So if you ever heard the expression, you know, a person has eyes in the back of their head, there's something to it. So the processing area of the brain that processes everything we see is in the back of our head. So I don't know if people who have said that know that. I'm not implying that. I'm just saying it is interesting that the vision part of the brain is in the back of the head. But let's move away from that for a moment. Excuse me. And let's move to the reward center there, which is in a darker purple shade. And that's the area that most of us are familiar with in terms of the dopamine center. And people who have addiction are viewed as really activating that reward center. It's in the middle part of the brain, and it happens to also be a bit far from the other area of the brain, which you see a little bit towards the top and to the left, which is in the bluish area, which is the judgment center of the brain. And that's important because that bluish center of the brain is part of the new science. What we've come to learn is that the reward center, the nucleus accumbens area, does send projections to the prefrontal cortex, which is where that blue section of judgment exists. I mean, can we go backwards? Right, so again, that blue section of the judgment area is where we now know, that the reward center sends nerve projections to. Now, what I want you to think about in terms of the nucleus accumbens, the reward center, think of that as the accelerator or the gas pedal in a car. That's the go button. That says, when I get my medications, I feel good. I'm going to keep going for that. That's the old theory that a person would just keep going and going with the go button, the reward, the dopamine center. But now we've learned that when you continuously fire the dopamine centers of the brain, there are nerve endings that go to this new area it's not new, it's just new in terms of the science, that projects into the prefrontal cortex. And the prefrontal cortex then has a looping mechanism whereby with that red arrow, it feeds back onto the go center, the dopamine center, and it is actually the stop button, if you would. Again, I'm sort of keeping this in simple terms because this is the language that we use with our non-clinical staff to explain to them the new science of addiction. So imagine addiction is not just the go button. I get my drug and I feel high. That's the go. But what seems to happen is when the person continuously presses on the gas pedal, the go button, the reward center, it ruins this feedback loop and the stop button gets destroyed. This is what is happening. Therefore, the person is unable to shut off the reward behavior. And this is critical to understanding how it's a brain disorder. And when this is happening, it no longer seems like a simple matter of a choice. If you don't have the ability to turn off the addiction behavior because this part of the brain in the prefrontal cortex is now damaged, it's difficult to imagine having somebody be able to just say no. So I go through this with our correction staff, our administrators, so that they can begin to shift their view of addictions. That just trying to tell somebody to knock it off or just say no, or why can't you just do what all of us do and just stay away from it? It's impossible if your stop button is not working. For those of us who don't suffer from an addiction, our stop button works and we don't do these kinds of behaviors. And it's part of the judgment, and the judgment would tell us, don't go near where your drug dealer is. For the person whose judgment area in the prefrontal cortex is damaged by addiction, they go near where their drug dealer is, which seems non-logical to us. And it would make sense because we have this prefrontal cortex working. But for the people who have an addiction, that prefrontal cortex, the judgment area, is not working, and therefore they end up near their drug dealer again, which seems illogical to us. And hopefully this helps explain that type of behavior. Now, what's also interesting is that prefrontal cortex of judgment is not fully developed in humans until about the age of 25. This is an MRI that shows that area of the brain, the prefrontal cortex. And if you can look carefully and see the white circle on the one picture of the brain that's mostly red, that shows it to you at the top. And then you see the top view right underneath that. So at age 5, that's what that number 5 is. You can see that anything in yet red is the most immature or not mature part of the brain. And it happens to coincide with that prefrontal cortex area of judgment. This is why children, and particularly adolescents, they don't have that stop button. They just go. They'll cross the street. They have no understanding that there's danger ahead because that part of the brain is not developed. And if you look at the red arrow in the middle that shows you with age, you can see the other areas of the brain turn blue, which are indicating more maturity in the brain. And the last area to develop at age 20, you see the white circle again. It still has some green that shows it's not fully formed. That's the prefrontal cortex. Now, this is important to understand because addiction is very common in young people. And this is part of the reason why. because their stop button in the prefrontal cortex has not even formed, and they're already damaging it by using drugs. So they have two reasons why they are particularly prone to addiction. Their stop button in the prefrontal cortex is not fully formed, and then they're taking in drugs that harm whatever is already trying to form. So this is proof, and I've distilled some of these slides to just a few to show you the science behind addiction. This really does help explain why it's not just a choice where a person can say no or avoid it. It's based on biology, it's based on this time frame, and this can help guide us in terms of how do we treat it. So let's go through a little bit of some information on the natural rewards and what we know about the dopamine system. So here I have two slides, one about food and one about sex. So you can see the one on the left, we all have a certain amount of dopamine, the go button, if you will, that reward system, whereby if you see the number on that left graph, it's at 100. So everybody has at baseline 100 as the number that we use for the release of dopamine. And when we ingest food, you can see that bar graph jumps up to about 150. And then that's after you eat, pardon. And at the bottom of that graph, you can see the time frame going out to about an hour and a half until it reaches baseline. So food gives us a bit of a reward of dopamine up to 150. Go to the graph on the right. So sex. So there you see the act of sex jumps our dopamine level to 200. So it's more than food. And then it doesn't go back to baseline. It stays up at around 150 for a number of hours. So I'm pointing this out because we're going to now look at different drugs. But I just want to show you these systems of the dopamine level are exquisitely fine-tuned over time, over evolution, to drive our behavior. And so two basic human instincts, procreation and food, are very specifically coordinated in the brain so that we can continue as a species. Now, look what happens to the dopamine levels when we look at different drugs and products. So the top one is morphine, but you can substitute heroin for morphine because actually we measure morphine from the heroin as it's converted in the body. And you can see that morphine goes up to 200 after 1 hour. So the level of dopamine released is similar to sexual activity, but that it stays elevated close to 200 for a number of hours, and it only drops down after about 5 hours closer to the baseline. So in some sense, we see that heroin looks a little bit like the response to sex. It goes up to 200, and then it lasts for a number of hours and then slowly gets down to the baseline of 100. If you look at the slide below that, let's look at the nicotine, just to understand how the addiction to nicotine is very, very difficult to break. You can see that it peaks at a level of above 200, about 225. It spikes up, and then for about 3 hours, it stays at 150. Let's go to the next slide, cocaine. You can see that cocaine jumps up to 300. How addicting is that? So the dopamine rush that people get from the use of cocaine, and we saw that with crack cocaine, that epidemic many years ago, the dopamine skyrockets to about 325, 350, and then after 5 hours, it begins to level out to about baseline at 100. And alcohol, again, goes up to 200. You have a big spike, and then it lasts about 4 hours or so. The morphine and the alcohol levels, they show you the different usage. The graphs are just to show whether you use a little bit or a lot of either alcohol or heroin. But the overall graph is what's important. You get a big spike, and then it takes a few hours for it to come back to normal. Let's move on to this drug, amphetamine. Look how amphetamine blows all the other drugs away. The spike in dopamine goes up to 1,000. So much higher than cocaine, much higher than food, sex, or any of the other drugs that I mentioned on the previous slide. And it lasts 5 hours before it begins to approach baseline. Methamphetamine is even more powerful than amphetamine. So imagine that I don't have one to show you on methamphetamine, but I just showed you amphetamine. And imagine that this spike would be even larger with methamphetamine. Okay, so we've talked a little bit about the science of addiction, and now let's talk about what happened in the DOC in terms of our culture shift. It started about 6 to 7 years ago. We were using the therapeutic community model, which did not incorporate any medications for addictions, and we switched to a more holistic medical model. We opened up our licensed substance use disorder treatment at 2 of our prisons. For the male population, it was at Mid-State Correction Facility. For the female population, it was at Ed Mahan Correction Facility in Clinton. And this was licensed by the Division of Mental Health and Addiction Services here in New Jersey, part of the Department of Human Services. And the other shift is that we began to treat people with a substance use disorder problem immediately upon entry, which was a shift from what we used to do, which was we would wait and offer them the TC model when they were about 1 to 2 years before they would leave, which was unconscionable that we would wait, but that's what we would do. And currently, we do incorporate medications for opioid use disorder, but understand, please, that that the use of medications is not a mandate of licensed substance use disorder treatment. Those are separate things. In other words, DMOS in New Jersey only licenses the talk therapy part of your program. It does not license the medications. That's by the individual clinicians who are reporting back to their medical boards. So it's a medical piece, and it is not licensed by the Office of Licensing. In the Department of Corrections, we've also added peer navigators to the intensive recovery treatment support. So at release, we find that this has tremendous synergy with the offering of medications for opioid use disorder. Our peers come in 6 months prior to the release of a person who's incarcerated, and then they follow up with them in the community for up to a year. My personal view is that the peer navigators are probably more impactful than the medications, and I say that because you can have the best medication in the world. If it doesn't get into the person's system, it's worth nothing to them. And the peers have been exquisite at getting the offenders to trust that we are here to help them get better, and so they're more willing to try the medications. Many of the peers have lived experience either as being in recovery themselves or having been formerly incarcerated. And about 6 months ago, we began to hire peer specialists at intake who can again encourage the offenders to accept all forms of treatment, particularly the medications. So we do this to address both personal bias that people still have about medications and system bias that did not encourage the use of medications. And we need to also be respectful that for some people, treatment will include only talk therapies, and if that's what works for them, we have to respect that. I put in there that training is the key. We train our uniform and civilian staff together so that they understand that learning about the new science of addiction is something that both the healthcare team as well as our correctional staff need to learn about together, that they're on the same page. Now, that's what happened in the Department of Corrections. We'll shift quickly to what's going on at the jails. The jails are independent of the New Jersey Department of Corrections. However, in 2017, the Department of Corrections received some state grant money under former Governor Christie, and they donated a certain amount of that money to the jails to try to jumpstart their own, I'll say the medication-assisted treatment program, because that's what we were calling it back then. However, we limited, and I say we because we were the Department of Corrections, we limited this money to only the medications. What we did not understand is that many of the jails needed the infrastructure for the talk therapies. They needed training. They needed many different things to help have a combined medication and non-medication approach to addictions. And so we began to also coordinate our efforts with drug court. In Atlantic County, they've now changed the name of Recovery Court, and they have introduced medications with the drug court also about 5 years ago. So they were advocates of using medications for opioid use disorder. The other thing that has affected our jails is the criminal justice reform, particularly bail reform. Whereas a person used to stay in a jail when they were arrested for a drug-related matter for several months. Now, because of bail reform, if they're a nonviolent person, they're usually released within 24 to 48 hours. It's very difficult to impact a person's life when you're only there for 24 to 48 hours. It begins to look more like an emergency room model where you go in, and I say this for a reason because the emergency rooms have now started to offer a Suboxone as MAT and move away from detoxification. And our jails are adopting a similar process. Atlantic County Jail has been using methadone to treat people with an opioid use disorder. And Morris County Jail also introduced methadone a number of years ago. Camden County Jail, more recently, using some of the seed money from the Department of Corrections in 2017, they expanded that to include all medications about a year ago. And the hope is that we can expand this use of medications to all the other jails. The Department of Corrections is working with the Department of Health as well as DMOS since 2019 to provide additional funding and additional technical services since 2019 to the jails. We still have some barriers to exchanging information. However, those are beginning to lessen as we get more cooperation amongst different entities. Our next objective is the community cultural shift. Treatment providers have to get their DAX waiver. In 2015 and 2016 in the Department of Corrections, myself, along with the folks who provide the healthcare services for the Department of Corrections, which is Rutgers University Correctional Healthcare, together we attended a DAX session, and everybody then got their X waiver. And it took us a few years to begin to be able to use that ability to write prescriptions for buprenorphine, and that'll become important when you look at the data. I'll explain that on a later slide. But just keep in mind that, as mentioned earlier, the emergency departments now have a different way of treating pain using the ALTO algorithms, which are alternatives to opioids. And, that little cartoon there with the smiley faces became one of the reasons that we saw big abuses of prescription opioids, because it became the fifth vital sign to ask for levels of pain. I'm not advocating that we not ask about pain. I'm just saying that there was too much of a concerted effort to assess pain and treat every level of pain with an opioid. And now the emergency departments treat addiction to prescription medications within the context of addiction, and they use alternatives to opioids. And we are also seeing in the community a shift in the rehab centers that they are now offering medications. About 6 months ago, Seabrook House on their pamphlet did in small handwriting, not handwriting, but in small print, state that they now offer medications for opioid use disorders. So it's really a shift even in the community. And today I'm here in the Center of Excellence, which was again created by former Governor Christie in an effort to educate our community about addictions. So let's bring all this together. We have the community. We see that folks who reside in the community go to corrections and then go back to the community. I call this the cycle of diversion. In other words, when they're in the community, we do everything to try to divert people away from corrections. We have drug court and many other things I mentioned earlier. And I also have a funny term for what happens in corrections. We have to supposedly convert everybody, so I call that conversion process, from taking people who generally break laws and turn them into angels. I guess that's the myth of what the society thinks happens in corrections. And then when we go to release them, I call that dispersion, so they go back to the community. And so we see this revolving door between the three systems, jails, prisons, and community. And I also want to give a shout out to my colleagues in parole. We work very closely with them, and they have done a wonderful job of offering medications for parolees coming out of the prisons. And they've done a tremendous job in New Jersey to divert people away from jails and prisons into treatment. So I'm going to, for the sake of time, skip over a little bit on our reentry to parole or at max out to the community, but just to understand that parole does a wonderful job of helping people be connected to treatment. Those who are under max out do not get the benefit of extra supervision when they go back to community, which is an unfortunate thing. Parole really does a great job of helping people to stay in treatment. Okay, we're getting close to the end. I'm going to give you some correctional outcomes. There is research out of Washington that showed that there's 129 times increase in the risk of death in the first 30 days post-release from incarceration. That is a huge increased risk. We see it in New Jersey as well. Many folks will remember Rhode Island was the first to show coming out of corrections that when you offer medication, that risk of death drops tremendously. I think they were able to drop it by about 40%. I mentioned to you about the intensive, the IRTS system that we have in the Department of Corrections. Preliminary information shows that we've been able to decrease the number of overdoses post-release, and the number of deaths have gone down. Our peer navigators also offer a ride. We found out early in our program that several people overdosed within the first 2 days of release from our prisons, and the peer navigators asked if we could offer them a ride in a car back to their home to ensure that they actually get home. We actually had a few cases where the peer navigators were with our formerly incarcerated person on the bus, and the person escaped from the bus, and I say escaped because they jumped out and were noted to meet their drug dealer, and then we had a few deaths that way. So now we're able to offer a ride directly from the prison in a state car that is used by the peer navigator to drive them home, ensure that they are home. And the incentive is, if they allow us to take them home, the peer navigator will offer them a smartphone. And the importance of the smartphone is that they can communicate with the person and do check-ins, texting them to see if they're okay and if they make it to their appointment. If they don't make it to their appointment, they can arrange for an Uber or Lyft ride. So all of this is to help decrease overdose and deaths post-release. I do also need to mention that many deaths post-release are some suicides. Many overdoses are suicides. It's not talked enough, but it is a piece of it. The other reason that we're very interested in providing services at release is that it's a holistic harm reduction. We are decreasing the transmission of HIV, sexually transmitted diseases, hepatitis A, B, and C. And I'm going to end on some information that treatment reduces drug diversion within the prison setting. So the next slide shows the data that I received in our lab. So all of the offenders are randomly drug tested. We randomly drug test about 2% of the population every month. So starting in 2015, these are the results of that test for 1 week in December. At the bottom, that's where I would focus your attention. Look at the number of opioid positives. It's 10. That means that out of a random sample, 10 people were testing positive for opioids of some sort. Now remember, opioids does not include Suboxone because Suboxone has its own lab test. So out of the 10 that were testing positive for opioids, 7 were prescribed opioids. And look at the number of people who were testing positive for bup. That's 7. And how many were prescribed buprenorphine? Nothing, because in 2015, we were still under the old regime, stigma. We were not offering buprenorphine. So nobody was getting buprenorphine, but at least 7 people were getting it illegally. Let's look at the next year. Again, now it's 2016. Thank you, Clement. So again, the same time frame in December, and you can see the number of opioid positives was 3. The number prescribed was 2, so it went down. Why is that important? You remember I had said that in 2015, that's when, as a system, we all got our DEAX. The first thing that we had to do, though, was to address what the emergency departments were doing, which decreased the number of opioid prescriptions for pain. So this is reflecting how we saw less prescriptions for opioids and less findings when we were doing random sampling. However, look at the number of buprenorphine at the bottom right, 8, which is more than what it was in 2015. Still, nobody was being prescribed buprenorphine, so nobody was getting it legally for an addiction. Look at 2017. Again, focus again at the bottom. The number of opioid positives was 3. Look how the staff did a tremendous job. 0 are being prescribed. So we went from 7 to 3 to 0 being prescribed. Now look at buprenorphine. It jumped up from 8 the previous year to 12. How many were prescribed? We found our first prescribed. We started offering buprenorphine in about November of 2017, and we found one which was only 8% being prescribed buprenorphine out of the 12. This is in 2017. Look what happens in 2018. Again, same time frame, December. I focus your attention to the bottom. Number of opioids, it's down to 1 on a random find. How many were prescribed? 1. Well, that seems appropriate. I'm sure we have a person who has cancer or something like that. So the numbers look more reasonable. Look at the buprenorphine. It goes up to 13. But check this out. 9 of them are prescribed now, which means 69% of the people who test positive for buprenorphine are being prescribed. So the number of illegal buprenorphine is going down. Look at 2019. Now, the number of samples has gone up. That's why it looks so small. But again, I focus your attention to the bottom area. The number of opioid prescriptions, 1. So it has remained low. How many were prescribed? 0. So 1 illegal opioid usage. Look at the buprenorphine. We're up to 54 finds. We randomly test the same number. Look how many were on buprenorphine. 46, which is 87%, meaning that of the 54 buprenorphine finds, we have 3 times more than in 2018, and only 7 were bup diverters. So only 13% are diverting buprenorphine. Over a number of years where you saw the data for at least 3 years straight that I have the data, every buprenorphine prescription was a diversion. We're now down to 13%. Okay, final slide. Well, I will tell you that is the final slide in a way, but I just wanted to let you know that I just did this result in 2020 in February, and the numbers were almost identical to what you see here. And so it is sustained, and I'll be happy to take questions at this point. Thank you very much for your attention.
Thank you very much, Dr. Kaldany, for coming to speak on this very important topic, and just want to open the floor to any questions. All right, so I'll start off with a couple of questions here. In presenting all these data, I think you've seen that buprenorphine prescriptions have gone up, and there's been, much greater. It shows the importance of, what we're doing in terms of tackling. But what do you see are some of the continued challenges in the DOC or even in the jail system, and what would you like to see change in the future?
So we still see pockets of New Jersey where there are not enough prescribers of buprenorphine who do not have their DEAX waiver. So that's a big hindrance. We still see stigma in terms of folks who don't understand the new science of addiction. And that, unfortunately, is seen both in the healthcare field as well as in the non-healthcare field. It is partly due to some of the factors that I mentioned to you earlier, that we were all programmed to view addiction as something to be punished rather than to be treated. The science is relatively new. So those are two areas, working on stigma and getting more physicians and other clinicians, because nurse practitioners and physician assistants can now prescribe buprenorphine, and we need to encourage more people to have access to these kinds of treatments.
I do have a question on the line. Says, are the slides available to participants? And yes, we are going to be launching our Learning Collaborative slides soon, and as well as a YouTube channel for everyone to view this information. I do have a question on the line. It says, does the state have funding to address the substance use disorders in the prison system?
That's a great question. I appreciate the person for asking that question. So I had mentioned that former Governor Christie had set aside out of state funds $100 million to the different state agencies, and a certain amount of that funding went directly to the Department of Corrections, the Department of Health, Children and Family Services, and other state agencies to address the opioid crisis. So I'm not sure, because I don't know the answer to how actually the governor had assigned $200 million. I misspoke. And Governor Murphy has, in subsequent years, assigned $100 million per year to the state agencies just to address opioid use disorders. We're trying to use that as a launch pad to treat all substance use disorders, but it certainly has started with the opioid crisis, because we see the most deaths related, at least on the news, we hear about the deaths related to opioids. It is the one that can unfortunately cause the most death. But overall, deaths related to alcohol still are more significant than opioids. We just don't hear about that. But yes, the state does have the funding to address the disorder in the prison system. We're very fortunate that both governors, past and present, have been supportive of our efforts.
Thank you. Anyone have a question?
Yeah, I have a question. Comment and a question as well. Well, in our center, I'm speaking specifically, we have a lot of challenges about treatment, prescription, and there are other challenges too that our population are facing, things like housing, homelessness, and transportation. There are other factors that are affecting their need to or trigger them to use. Okay, so if we give somebody prescription, they go home, they take medication, they have nowhere to stay. Like one of my patients said, I have nowhere to go home, and said, no, I still have to hang around with the people that are using and the drug, that I have to be nice and do whatever they're doing. Now, all these millions of dollars that are being funded, are they just for treatment strictly, or are these people offered other things like social services, like, as I say, housing, transportation, or even job training? Are they being used for that?
My answer to you would be that it's probably not enough in that area that you're mentioning. So those social determinants that you're talking about, we've discovered are very, very important. And there's probably not enough being done to address that. At the Department of Corrections level, we had some federal funding that was able to be used to assist with housing and with vocational training. We also have some built-in monies that address vocational training now, not specifically tied into opioid use disorder. So we are addressing those areas, but those are areas that I feel we need to have more community involvement in. It's beyond what the Department of Corrections can do or the jails can do. You are correct that if a person has an addiction, the medication won't prevent them from going back to where they were if that's where the dealing was going on. The other unfortunate reality is that many people have both an addiction and use selling as a way of supporting their addiction. So in our treatment programs, we do permit people who have had some level of distribution in addition to their addiction. However, if the preponderance of their behavior is criminogenic in nature, in other words, if they mainly started out as a person who's a distributor, seller, then we have to treat that person differently and treat them more with criminogenic interventions as opposed to treatment interventions. But those that have some distribution and criminal behavior, mainly to support their own addiction, with the treatment, then that criminal behavior tends to drop out. But it's a difficult decision as to on what side of that balance does a person fall in. This is a very important part, and it ties into then housing and vocational training, because if you were involved in work and you developed an addiction, then maybe you can go back to resuming that job or vocation that you were doing. But if your main job was selling, then that's a problem, because you were living on the street and you have not developed enough other legal vocational skills. And so that needs to be addressed in a different way.
Thank you for clarifying that difference in terms of how a patient is treated. I think that's a very important point to bring up. Just have a couple questions. I think that's maybe all the time we have for this learning collaborative. So what decides when and how an inmate is eligible for medication for opioid use disorder versus verbal counseling only?
Thank you for that question. It's an important question to me. I believe firmly that I follow what the CDC and SAMHSA says, that there is we reject the one-size-fits-all model. In other words, we offer every incoming person who's incarcerated to either do counseling, medications, or both. But we educate them that doing both, similar to somebody who has a major depressive disorder, having both produces a better outcome. However, we have to meet the person where they're at. And so that decision happens between the offender patient and their clinician. And so we don't mandate verbal counseling. We don't mandate medications. Everything is voluntary. And so it is done on a case-by-case basis. That's how we handle it.
The one last question. Do we know the recidivism rate in the prisons, such as mid-state correctional facility, when offenders are on a substance use disorder program?
Unfortunately, I don't have data yet that can differentiate those two targeted populations. We've not been open long enough and have people in the community long enough. So recidivism rates are usually reported at 1 year out, 3 years out, 5 years out. We haven't been open long enough to get that information. We're hoping to, in time, do that, but we don't have that information at this time.
I think it's great, like you said in the beginning, like long-term outcomes of everything we're doing is going to be.
Right. I was able to show some data about what's happening for 5 years in the prison, but I don't have it yet outside. And then again, the DOC doesn't follow the folks, so that's the other confounder. How do you follow them? They're dispersed everywhere. So there's no one agency that can follow people who are released. That's why it's more difficult to get to that answer.
One more comment here. And then I think that's our final question is, you cite a 40% reduction in fatalities for those receiving continued treatment after release from prison. Was that statistic referring to medication treatment specifically?
Yes, but with the caveat that that was out of the 40% reduction was in Rhode Island, not in New Jersey. Just keep in mind that was out of Rhode Island, and they specifically cited the addition of medication for opioid use disorder treatment. That does not mean that they were able to compare medication versus talk therapy only. I'm just letting you know the 40% was if the person was on medication coming out of the Rhode Island system, there was a 40% reduction in overdose deaths. But some people were also receiving talk therapy. So I just wanted to make clear that it was an overall reduction in fatalities, but it was not hitting one form of treatment versus another. It was a naturalistic study. It was not in advance knowing what arm of the treatment you were going into. That's very difficult to do. It's almost unethical to say you'll only get one versus the other. So those kinds of studies, I don't know. Maybe some people are doing them. I don't know how you get around that ethical dilemma of not offering, let's say, one or the other. So most of the studies will be done after the fact and comparing groups.
One more quick question.
Sorry. Initially, I didn't say what I do. I'm a nurse practitioner. I work with Dr. Zobo, and this question is in relation relates to what I see. We do receive a lot of released ex-inmates, and sometimes most of them come when they're released. They have prescriptions, or maybe just medications given to them, or they're already given Vivitrol injection. So, and some don't. So my question is it a mandate, some kind of a universal thing, or it just depends on what prison or jail they went to? Because some don't have, and then sometimes they're out, they have an appointment to come maybe a week or two, and they don't have medication. Some come and they're like, oh, I have a 2 weeks worth of medication. How's that?
Sure. Appreciate you asking that. So the department is mandated by our own policies and procedures to provide 2 weeks worth of all medications that a person is on coming out of the prison system. Again, I can't speak for the jails, but for the prison system, 2 weeks worth of medications in hand, actual medication in hand. And then, depending on their needs, they may be given a prescription for up to an additional 4 more weeks of medication. But that's just a prescription. And therefore, everybody is signed up through Medicaid on the presumptive eligibility. They can fill the prescription. When it comes to Butte, we do give a 30-day supply because it comes as a packet of 30 strips. We use Suboxone. So we don't break up the pack. We give them a sealed pack of 30-day supply. So I can't speak for my brethren in the jail system. I don't know what they're doing. They have a different mandate, but out of the state prison system, that's the routine.
Thank you.
And we'd be happy to encourage that you get records from us so that you can see what the treatment was, see what they're getting, how they were doing. But you would need to get the release, and we're more than happy to send those records.
Thank you.
Well, I think that's all that we have. Thank you so much, Dr. Kaldany, for coming to visit us here at the Northern New Jersey Center of Excellence and talking about this very important topic. And I think we're all talking about how to really reduce opioid use and use it only when necessary, as we discussed in terms of the initiative in the DOC and in the ED, and to utilize medications for opioid use disorder, I should say as well, in all treatment settings. So just want to remind everyone on the line, our next Learning Collaborative is on Wednesday, March 25th. It's going to be on a topic on respecting diverse experiences and how to reduce stigma, particularly amongst the peer navigators. So if you could join that webinar, it's from 12 p.m. to 1 p.m. on March 25th, 2020. Thank you very much to everyone, and have a great weekend, and enjoy the rest of your day.
Thank you for inviting me.
Thank you.
Thanks for those questions. Those are really
Thank
great
you.
questions.
No, it was really, I'm very happy because I see these clients.
You see them now.